Mr. Knowles, good afternoon.
Afternoon, Senator. Chairman Yaw, Vice Chairman Wozniak, other distinguished members of the board here, and the Rural Pennsylvania Board of Directors. On behalf of everybody at Clearbrook Treatment Centers, we would like to thank you for the opportunity to discuss the explosive growth of heroin, opiates, and opioid dependence and its impact on us as citizens. On a personal note, I just want to, my name is John Knowles, and I'm a person in long-term recovery since November 29th, 1984. And I'm a statistic of the last epidemic we had, and that was cocaine. And because people like each and every one of you take the time out of your day to care about people like me, I've experienced all sorts of wonderful things in my life, and it has had a ripple effect on my family and many other people. And if they don't say it enough, I just wanted to say thank you on behalf of those of us in recovery. I've been a provider of substance abuse services for almost 30 years. I've witnessed a lot of changes in the using habits of the folks that we serve, but there is none that instills the level of concern and fear that I have about heroin, opiate, and opioid addiction. Pennsylvania is home to some of our highest quality, cost-effective care for substance abusers and their families, and we've got some great laws that really determine how we fill those beds and how we reimburse that. Yet we continue to climb and in the statistical ladder in terms of overdoses and the effects that substance abuse has on us. If we've learned anything from our past epidemics, it's that we're not going to be able to prescribe or arrest our way out of this epidemic, and that a comprehensive continuum of treatment and care and the expansion of case management services is really what's going to work for us. We know from statistics that almost 100 people a day die from overdoses, that more people die from overdoses on heroin than gunshot wounds or motor vehicle crashes. We've seen at Clearbrook, I can tell you that we have seen a marked increase in the patients seeking treatment in terms of their addiction properties. In 2013, 56% of our admitted patients reported heroin, prescription narcotics, or opiates as their drugs of choice. 69% of those were male, 31% were female. In 2014, the figure climbed to 59%. The significance of this is that it's about a 30% increase over previous years, where at best we would often have approximately 10% to 15% of our population. Our largest population centers, individuals, are in terms of admissions were, which until earlier this year when we closed our adolescent center, 12 to 15-year-old girls and over 45-year-old women. And that was the largest population of individuals that we saw with prescription narcotic or heroin addiction. Also of note is the 31% female figure is about a 10% increase over what we would traditionally see in inpatient settings where 80% male, 20% female were present. These patients present with very unique immediate and post-acute withdrawal symptomology, and a lot of this post-acute withdrawal symptomology seems to be what we're talking about in terms of long-term care. Initially, we see a lot of poor self-esteem, a real flat affect, depressed mood. As a result, these patients have developed a desire to leave treatment prematurely, and we see spikes in our increase in those individuals who do not complete treatment successfully. There's a strong feeling that hopelessness can't occur. A lot of these individuals, and what we have seen a spike in of late in the last 12 to 18 months, is the use of benzodiazepines such as Xanax and Librium in order to self-detox or self-quell the symptoms of withdrawal. This creates an even greater danger as the withdrawal from these drugs is life-threatening. While you can die from the use of heroin, you will not die from withdrawal. You can die from withdrawal from benzodiazepines or alcohol or other substances that they use to quell some of the symptomology of the heroin or opiate or opioid withdrawal. We expect to see a significant increase in this multi-substance abuse and addiction. As people, one of the other issues that we're seeing in terms of profile for patients is there's a look for an enhanced high. It's not just good enough to get the high from the heroin or get the high from the methamphetamine, the they're looking for an enhancement of that. Some of these synthetic drugs that have popped up in the various levels, we expect to see that that's going to continue to cause some problems and really changes the way that detox is done. As several people have mentioned before, we have a model that is set up for a 28-day treatment. That's set up, and it was very successful for alcohol. We know that 90 days is the time choice for heroin, yet very rarely, if ever, are we able to achieve getting that period of time. So part of that is there's a number of influences that have come up. Part of it would be that in 2014, early 2015, we're seeing the impact of some of these parity laws in Obamacare in terms of providing a third-party reimbursement to access of care. In Pennsylvania, we are the home of an Act 106 law, a bill that mandates minimum benefits to treatment of alcohol and drug addiction. Essentially, Act 106, the value of Act 106 is it clarifies pre-certification. It says that we will pre-certify people based on the PCPC and that the individual at the facility can make that decision. Individuals who are not covered under Act 106 don't have that ability. They don't have that class. So the insurance company then gets to make the determination as to what qualifies an individual to commit to treatment. Also, the Act only represents a portion of insured public, and gaps in the bills expose anyone who's not a group policy holder, self-funded plans, et cetera, does not have access to this. One of the issues that we're seeing, I can give you several examples, but we just recently, individuals who are arrested and put into jail, if they are unable to secure treatment within a 3 to 5 day period of arrest, oftentimes the insurance company, if it's not an Act 106 covered plan, will say to us, well, he's detoxed, he's in jail. Jail serves as the detox, and he does not need your level of care. And so you should just send him to outpatient care. We won't qualify that, and that happens quite often, actually. So this severely limits some of their access, and with the Affordable Care Act, a lot of the people, and we spoke earlier to the working class and the blue-collar population that is primarily, these are the folks who are accessing these Affordable Care Acts, or Obamacare, as people like to call it. However, what happens with these is these are often individually purchased plans, so they're not part of group funding. They don't get Act 106 coverage. They don't have. They have very high deductibles. It's not unusual for us to see a working class person living paycheck to paycheck with a $5,000 deductible and maybe a $2,000 out of pocket. Extremes of that, I just recently had one that it was a $20,000 deductible. Our cash price for treatment is $18,200. I mean, you could pay for treatment and still not access it. And there's a false belief that simply having the benefit allows you access to care. We also have seen a real change in the inpatient, in particular in the inpatient treatment field. There's been a significant increase in investor-funded mergers and acquisition over the last 12 to 18 months. As with all of healthcare, substance abuse treatment has become a real darling of Wall Street, and the balance of nonprofit and for-profit providers has shifted pretty significantly, and as a result, aggressive marketing campaigns by some well-financed for-profit providers. Some of you may be familiar with what's called the Florida model, which uses kind of skirts the managed care policy by providing free housing and utilizing other types of benefits. The laws in Florida allow that. The laws in Pennsylvania are a little more strict, so that's how they get the name. But essentially what happens is you come down and you go to outpatient every day, and we have you stay in a hotel that we keep an eye on you at, and then everything is done on an a la carte basis, and you're billed for urine drug screens, and you're billed for your psychiatrist visit and your psychologist visit. However, those bills go to your medical plan, whereas the provision of outpatient services go to your behavioral health plan. You have the appearance of a $5,000 bill for outpatient services, but you have a $25,000 medical bill. So the insurance company is going to catch up to that, and they'll figure that out. But the value of that, unfortunately, is it's not a bad system because it allows us to get people about 90 days of treatment. Unfortunately, when they finish with that, they come home and they've exhausted their benefits, and so the individual doesn't have the ability to seek any other level of care because the insurance company, as a third-party provider, has paid out all that they're going to pay out during that calendar year. So, again, this limits those individuals who we would want to see in a longer term. What we know is that it takes a good 18 months to 2 years to really get people focused. And that it takes, if we can get them to 5 years abstinent, that their chances of having a lifelong recovery is the numbers are very high. However, if they run out of those, and the ability to do any wraparound services or case management services are non-existent, so we think that it's going to be an interesting 12 to 18 months ahead of us as this shakes out in terms of the treatment field. We believe we represent pretty well the different providers of inpatient services across the state. Big issue for us with some of this is that it limits our ability to provide reduced care or free care, where we used to, or also to provide individuals in the community who access public funded care. The percentage of that providers will be able to offer will shrink because the payer mix changes pretty significantly. So I thank you for the opportunity to provide testimony, and I appreciate your commitment again, personally and professionally. And if you have any questions, I'd be happy to answer.
Dr. Falvo.
Yes, thank you very much. I'm not really familiar with Clearbrook. Could you tell me about how many patients you see per year there?
Our adult facility, we bring in 11, I believe it was approximately 1,100 patients. I could get you the exact number, but 1,186, something along those lines.
And you said that one of the largest jumps was 12 to 15-year-old females?
As of until February of this year, we provided adolescent services. We've been around since 1972, our adolescent facility, and we were unable to sustain the adolescent facility, and that was closed and sold in February of this year.
But you were seeing a jump in that age group?
Yes, we were, yeah. It was probably the largest increase is in young females. In fact, our population of males and females in that setting went from about 80-20, 70-30 to almost 50-50.
Okay. And do you know, were most of them dual diagnosis for that age?
A lot would have more from a conduct disorder or a intermittent explosive disorder. Tended not to have some of the more traditional ones at the younger age. It tended to be more of a and there were
Behavioral.
That population tended to have some very. I was the chief administrator there for before it closed. We tended to have significant environmental issues also, and so you had the genetic predisposition and some of that stuff. But a lot of these kids were, and a good portion of our population came from rural counties.
Just one last thing. You mentioned the treatment with Xanax and Librium. Were they self-medicating with those drugs as well?
Yeah, they use them to quell the symptoms of withdrawal, so they're self-medicating. It's not unusual for me. I receive about 30 calls a day for treatment, and probably half of them will tell me that I'll say, "Are you okay? We can't do anything for a day or two. Are you okay? I have some Librium and Valium, or I can get some." And they'll explain to you how they're going to self-medicate or taper themselves.
Okay, thank you.
Senator Wozniak.
Thank you very much, John. Just the question is, in your treatment center, how many are coming from the judicial system that are ordered to your treatment center, and how many come in voluntarily?
We're a private nonprofit, primarily working class, middle class population. You cannot be court ordered per se. You can be court ordered to treatment. You can't be court ordered to our treatment facility. So we become the option. We become the best of your bad options, so to speak. Probably 20 to 25%. I can't get you the exact figures. Come from the legal system. I probably do 2, 3, 4 evaluations a week in the jails. Well, it's probably more than that. It probably was more. It's probably closer to about a third are involved have some involvement in the legal system, and then probably another 15 to 20% are in some type of IP program or drug court program, something along those lines, and they've relapsed, and then they're looking for some type of. So direct prior to sentencing, direct arrest, and to come in is. Probably, I would guess about 20%.
Okay.
Yeah.
And what I want to get to is, okay, those that are going through the legal system, using your facility as an option, because they have other places to go, do they have the same results as those that went voluntarily? I'm looking for the motivation. Some are forced into your situation.
There's no question. All the statistics and all the figures show that coerced treatment is actually more successful. Part of that is because they have more resources when they leave here. Not unlike if you're a lawyer, you have, through the bar, you have access to some great case management services. If you are in the legal system, you have access to some really good case management services. If you're Johnny Knowles and you're working selling bar supplies, you get out of treatment, you have 60 visits. And so there are more resources available for that population than there is for the working class guy who's going to work every day and goes home and didn't get involved in the legal system. So are their number? Yeah, they're better because they tend to have a better
Outcome.
they have better outcome because they have more access to wraparound services.